Hello everyone, welcome to the next module of our course, Proximal Stripping. So proximal stripping is one of the non-extraction method of gaining space, and first of all we will try to learn what is proximal stripping, what does the main name define. So proximal stripping is also known as interproximal reduction. This is a clinical procedure involving the reduction, anatomic recontouring and protection of proximal enamel surfaces of permanent teeth. This definition was given by Peck and Peck in 1972. This proximal stripping procedure is also known as slicing, Hollywood trim, selective grinding, mesodistal reduction, reapproximation, interproximal wear and coronoplasty. And this proximal reduction is actually one of the 6 keys to eliminate lower retention as given by Rayleigh-Williams. So whenever we want to ensure stability of lower incisors after treatment, we can go for proximal stripping. Now what are the indications? What all are the cases in which we can go for proximal stripping? So the first one is tooth size discrepancy. Let's say we have a tooth size discrepancy on both the sides of the arch. Left side teeth, they are bigger than the right side teeth, so that is called as tooth size discrepancy, and Ballard he advocated stripping to eliminate this kind of discrepancy. Interarch size discrepancies, as we perform Bolton's analysis to know the maxillomandibular disproportion in the arch. So if that Bolton's discrepancy exists, Kessling he preferred stripping to remove that Bolton's discrepancy. Tooth shape and dental aesthetics. If there is some kind of abnormal shape of the teeth in the arch, then Peck and Peck they recommended reshaping of enamel, which will also help in eliminating the lower crowding and improved dental aesthetics. Macrodontia size discrepancies, as I mentioned earlier also, if the teeth they are larger than the normal, then we go for proximal stripping. Crowding of mandibular incisors. So Hudson et al. He conducted a study and concluded that to obtain space for correction and prevention of crowding in the lower arch, stripping can be used. And to enhance retention and stability, so as quoted earlier also, Rayleigh-Williams he suggested proximal stripping to enhance the stability and decrease the chances of relapse. To simulate Stone Age man proximal atresion, Beck and Kessling in 1977 believed that attritional occlusion is of great benefit to man, and that proximal stripping simulates this if carried out regularly throughout the life. So if we do proximal stripping throughout the life, it actually simulates the proximal atresion what used to happen in the aboriginals. Normalization of gingival contour and elimination of triangular spaces above the papilla, thus it greatly improves the aesthetics and smile. Also, when we go for proximal stripping, that reduces the expansion and premolar extractions. Moderate dentomaxillary disharmony. So whenever mild to moderate crowding is there, we can correct that with the help of IPR or proximal stripping. Camouflage of class 2 and class 3 malocclusions. So if the patient is mild skeletal class 2 or class 3, we can avoid the extractions of maxillary premolars and correct the crowding and inclination of mandibular incisors with the help of stripping only. Then is correcting curve of spee. So as mentioned in the first lecture also, correction of curve of spee or its leveling, it requires space, and if it requires minimal space, then that can be created with the help of proximal stripping. Then what are the contraindications? What all are the patients in whom we cannot go for proximal stripping? So whenever the patients they present with severe crowding, that is crowding is more than 8 mm, we should not go for proximal stripping. Poor oral hygiene and poor oral environment, the patients who are not able to maintain the oral hygiene, since with proximal stripping we are roughening the enamel surfaces, there will be more of plaque accumulation. So chances of caries and periodontal diseases, that's on increase. Small teeth and hypersensitivity to cold. The patients who already have small teeth, we cannot reduce the enamel surface more, as this will increase the sensitivity. Susceptibility to decay and multiple restorations. The patients who already have caries and have multiple restorations, that means they have high caries index. So if we do proximal stripping in those patients, we are exposing the patient again to more of plaque, more of food debris lodgement. So more chances of caries and periodontal diseases will be there. Disadvantages: increased caries risk. So that is actually controversial. Earlier there were studies which suggested that enamel roughness is increased after proximal stripping. However, with new studies coming into being, modern techniques, they result in roughness that is comparable to the sound enamel. So that means there is no increased caries risk, but there are conflicting results according to this issue. Increased risk of periodontal disease. So reduced interproximal bone widths, they may predispose the patients with inflammation to more rapid progression of periodontal disease. However, in periodontal health, the reduced interproximal bone does not cause greater susceptibility to bone loss. Then inappropriate use of armamentarium, or I can say anything if used not properly definitely can be iatrogenic, but as far as proximal stripping is concerned, inappropriate use of the burrs or the strips may cause ledge formation, which promotes the adherence of plaque, bacteria, and definitely induces iatrogenic damage. Then is increased sensitivity, since we are reducing the enamel, and if enamel is lost more, that means you have exposed the dentine. So because of that, sensitivity can be increased, which can be treated with fluoride rinses. Now, since we have gone through all the disadvantages, so what instructions are to be given to the patients? First of all, informed consent is very much needed, because you are reducing the enamel surface, you are increasing the possibility of sensitivity, there would be irreversible changes to the teeth, there will be removal of sound tooth structure. So because of all this, the patients, they need to be treated with fluoride varnish or fluoride mouth rinse has to be advised. Now, what are the steps? How do we go for proximal stripping? So the first thing is a diagnostic setup. A diagnostic setup will supplement the treatment planning, and it will help in visualizing the final position and morphology of teeth. And the second thing is take an IOPA, measure the enamel thickness, and then check if you can go for proximal stripping or not. If enamel thickness is not sufficient, you should not reduce the enamel. However, if there is sufficient enamel thickness, it can be considered for routine proximal stripping. Then is access to the interproximal areas. So as a general rule, placement of fixed appliances and correction of rotations that are recommended prior to stripping. So initial phase of leveling and aligning should be done before going for proximal stripping. Whenever there is no proper contact between the teeth, you should not go for proximal stripping. First, create a proper contact or create a proper access to the area, then go for interproximal reduction. So I would advise you to place an open coil spring or at least a separator before going for proximal stripping. Step 3 includes an O2O or O3 inch brass or steel indicator wire, which can be placed gingival to the contact point to protect interdental tissue. So this will help in protecting the gingival tissue from being harmed by the proximal burrs. Or you can also bend the wire in this manner and place it below the contact area so as to protect the gingival tissue. So finally, the step 4, that includes the interproximal enamel removal. So mesodistal enamel reduction, it is performed by either manual or mechanical methods. So all these are the manually handheld abrasive strips, or these are the ARS burrs, that is air rotor stripping burrs, which are fine, tapered, thin. Then we also have diamond disc. Now these discs and the strips, they can be safe-sided or double-sided. That means if we want to go for reduction on only one proximal surface, not damaging the adjacent tooth, we can use safe-sided disc or the strips. Then how to ensure how much enamel we have reduced, that is the incremental thickness gauges are used for that purpose. So the early use of manual abrasive strips, it was time consuming and also produced irreversible residual furrows. So nowadays hand operated strips are reserved for minor enamel removal cases, and actually we go for air rotor stripping burrs or the diamond disc. So these safe-sided ARS burrs, they reduce the interproximal enamel and prevent scarring of the proximal walls. And finally, the recent systems, we have disc systems with oscillation movements which help in giving the geometric axis in relation to full 360-degree disc. And in order to protect the gingival tissue or the adjacent teeth, we have the disc guards, as you can see in this picture. The disc guards that fit over the handpiece or contraangle mounted diamond coated stripping disc, they help in protecting the adjacent tissues. And then these are the incremental thickness gauges which can be used to assess the amount of enamel removed. So the progress of proximal reduction can be quantified by means of these gauges. And finally, the finishing and polishing. So once we are done with proximal stripping, so as mentioned earlier, we are roughening the proximal surface, but we cannot leave it like this as it will accumulate more of plaque and bacteria. So we finish and polish the enamel surfaces with the help of either fine burrs or Soflex disc or the finer finishing instruments or 37% phosphoric acid gel as mentioned by Joseph and colleagues. Then is finally the topical fluoride treatment. So to enhance the remineralization capacity of the abraded proximal surfaces, it is prudent to prescribe a fluoride gel after air rotor stripping. On the other hand, Zekrison, he considers unnecessary a special topical fluoride application. He just suggested twice daily mouth rinsing with a weak fluoride solution is also sufficient for the proximal stripping cases. Now, very important question, how much enamel can be safely removed? So potential gain of 2.5 mm and 6.4 mm of space may be anticipated by enamel removal from 5 anterior contacts and 8 buccal contacts according to Sheridan, or as a general consensus, a measured 1 mm can be removed from the contact points of the buccal section, while stripping of the lower incisors should not exceed 0.75 mm at each contact point. So I would suggest you reduce 0.5 mm per proximal surface from the buccal or the posterior teeth, and anteriorly you should go for 0.3 mm per proximal surface. So concluding, the available literature, it indicates that reduction of interproximal enamel surfaces represents a valid therapeutic modality in the hands of the orthodontist. This technique, when carried out properly and in specific circumstances, may assist achievement of treatment objectives without compromising the integrity of the dental and periodontal tissues. So if you are following the clear indications of the stripping procedure, this procedure, it helps in creating space in mild to moderate crowding cases. Thank you very much. Now see you in the next module, that is another non-extraction method of gaining space. Thank you once again.